Good afternoon, everyone. First of all, I would thank the organizers and Dr. Amit to invite me for this conference. So today's topic would be image-guided tissue sampling. So, role of tissue sampling, why is it required? To prove the malignancy, one. Second, for guiding staging. And third is to plan the treatment. So there are various types of biopsies that are available in the present era, coming from the surgical biopsy, that is open biopsy, where you see the tumor, you take the multiple tissues from that and send for analysis. Then is endobronchial biopsies or bronchoscopy guided biopsies, where you place in a bronchoscope or a ebuscope and then take multiple biopsies. And third is a percutaneous biopsy. These are predominant for the peripheral lesion and central hilar necrotic lesions, where you can take multiple cores from the tissue, from the tumor or the tissue, whatever is there. So why image guided is more important? Because it is one, it is precise. You can target metabolically active lesion and less chances of repeating the sample, and it is safe because you can see the vessels pretty much easily on a CT scan or ultrasound, depends on what you are performing the biopsy. So imaging modalities can be multiple, like ultrasound guided biopsies or EBUS guided biopsies for mediastinal nodes, fluoroscopy guided biopsy to prove metastasis, and CT and CT fluoroscopy for doing lung biopsies and lung interventions. And last but not the least, when the biopsies are coming repeatedly negative, you do a fusion biopsy, that is PET is combined with the CT scan, and you can see in this image where there is central hilar lesion and with collapse consolidation. So why image guided has more significance? Because it is highly accurate, high sensitivity, specificity, and it is in the range of the sensitivity is in the range of 82 to 99%, and specificity is 86 to 100%, whereas accuracy is 64 to 97%. So coming on to the indications for the lung biopsy are, the indication is when there is a new nodule, when it is an enlarging solitary nodule mass, multiple nodules in a known case of malignancy, hilar mass or focal infiltrate. Whereas in the cancer, now with the present era personalized therapy, you can even subclassify and do molecular markers on those biopsy. Contraindication includes uncooperative patient. These can be managed with general anesthesia or deep sedation. When patient is having high positive pulmonary ventilation, that is where you require high chances of pneumothorax associated with it. Severe respiratory distress, pulmonary hypertension, severe interstitial lung disease, all those are relative contraindication. Coming on to the pre-procedure evaluation, things for evaluation. One is a CBC and platelet of the patient, which the platelet should be more than 50,000. The coagulation should be less than 1.5, and patient needs to have previous imaging, anticoagulants and antiplatelets inhibitor needs to be stopped prior procedure, and informed consent regarding potential complication, and that needs to be explained to the patient. So, does every lesion require a biopsy? Let's come on to this patient. So, this was a patient who was referred to our department for doing a biopsy of right upper lobe, left upper lobe. So, what you can see here is a mass lesion, but however, patient did not have a CT scan. So when we did a contrast CT scan, what we observed, there was a pseudoaneurysm which was communicating with internal mammary artery, and which was successfully embolized with the help of coils. This is an angiogram which is showing a pseudoaneurysm arising from internal mammary artery. And what you can see here is multiple coils which are placed and closing the front door and the back door of the aneurysm. So coming on to the positioning of the patient, depend on the location of the lesion. If the lesion is placed posteriorly, you need to go from a posterior approach, whereas if the lesion is placed anteriorly, you need to you need to go from the anterior approach. So this is a lesion which is posteriorly located. A patient needs to be done in a prone position, whereas this is anteriorly placed, which needs to be done in a supine position. So position can be supine, prone, lateral, decubitous, which needs to be explained to the patient. Coming on to the size of the lesion, when the large lesion, you need to be careful regarding the biopsy which needs to be taken from the solid enhancing component. And when the lesion is small, you can either go perpendicular approach or tangential approach, depends on your preference. A prone position is preferred while doing a biopsy, because the posterior part of the lung and the rib moves less than the anterior part, and it decreases the anxiety of the patient. And targeting the lesion, as I told earlier, the solid component wall of the lesion which needs to be targeted. So this are the three examples. So this is a central hilar mass close to the bronchus and pulmonary trunk, which needs to be targeted. This was a lung cancer patient already on chemotherapy and was on follow-up, and now and along with collapse of the use. So there is role of PET CT scan. So the answer is when there is repeated negativity, the biopsy, there is repeated negative biopsies, you can do a PET CT so as to confirm the lesion one, and where you need to target accurately. So this was the patient which had a central hilar lesion along with collapse of the lung. You can enter via collapse of the lung or posteriorly. It depends upon your comfort level. Another patient where there was this was where it has the semantic nodularity, which was showing through the lung. So coming on to the basic concepts, it has to be done in a free breathing motion because it is highly reproducible. Lingula and mediastinum can have cardiac motion artifacts. Chest wall vessels needs to be seen accurately, that is the internal mammary vessels, and the fissures needs to be taken care about. So always you need to enter from above the rib surface rather than from the under surface, and you can see below the rib there is neurovascular bundles which are present, and this is you need to enter parasternally if lesion is located, or lateral to the internal mammary vessels. So one needs to be aware about the fissures, the two fissures on the right side and one fissure on the left side, and you can see here we have entered and through the four pleuras, actually the parietal visceral pleura outside, and this is parietal visceral pleura of the fissure itself. So you need to avoid those, and this is where the fissural anatomy comes an important play, because the chances of pneumothorax reduces. The scan protocol is low kV, low MA, limited number of slices, coaxial needle, and local anesthesia needs to be given. So post procedure to stage and do a guided biopsy, that is endobronchial ultrasound guided. So endobronchial ultrasound is the scope which has the side hole in it, where you can take multiple biopsies through the side hole, and this is the EBUS scope which is there, and there is multiple you can do the needle. So indication of EBUS is small cell carcinoma, non-small cell lung cancer, sampling of the lymph nodes, diagnosis of the unexplained mediastinal lymph node, and a research tool for tissue banking. So on suspicious lymph nodes can be on EBUS which are round in shape, loss of fatty hilum, heterogeneous ecotexture, presence of necrosis. The advantage of EBUS is it's minimally invasive, real-time, safe procedure, and you can target varied amount of lymph node as well as central hilar lesion, and it avoids thoracoscopy and complications. Coming on to the limitation, it is operator dependent. The EBUS cannot image subaortic and prevascular lymph nodes. It is not available at all places. The cores are inferior. We need to do EBUS as opposed to percutaneous biopsy. So this is a node which is located all throughout the vessel. This is another paratracheal lymph node which is surrounded by 270 degree of the vessels, and posteriorly there is a trachea or a bronchus in all four images. So you can go with the EBUS scope and then do multiple FNACs or biopsies, and then and you can achieve the tissue diagnosis. So last is a take-home message. It is a minimally invasive procedure which is indispensable tool for diagnosis of thoracic lesion. It is very safe, effective, with a good accuracy, good sensitivity and specificity, and a good accuracy rate. It is a daycare procedure when it is performed by experienced radiologists. Thank you. If any doubts and queries, I am happy to answer.